First of all, I would like to thank the organizing committee of Liver Congress of Ho Chi Minh City Association for the Study of Liver Diseases for inviting me to talk on this special topic entitled Utility of Correlated Antigen and the Diagnosis and Prognosis of Hepatitis B Progression. When I started training in hepatology, that is more than 25 years ago, we used dot product hybridization to semi-quantify HBV DNA into 1+ to 4+. We only had qualitative surface antigen and E antigen tests. Later on, we have standardized assays to quantify HBV DNA, then E antigen and surface antigen levels. With more science advancement, starting from the early 2010, we had correlated antigen, and from mid-2010, we had HBV RNA. For correlated antigen, we measured a collection of a core antigen from complete and empty virion, secretory E antigen, and also a subunit of P22CR. You can see in this diagram that there are multiple roles of correlated antigen played in natural history, disease progression, complication, antiviral therapy of chronic hepatitis B infection. Correlated antigen also has an interesting role in occult hepatitis B infection. In this talk, I would illustrate the roles of correlated antigen with respect to the natural history of chronic hepatitis B, correlations with other established markers, relationship with E seroconversion and long-term complications, treatment effect on correlated antigen, and finally, role of correlated antigen in HBV reactivation in patients with treatment cessation and in occult hepatitis B patients receiving immunosuppressive therapy. So, correlated antigen in natural history of chronic hepatitis B. This diagram shows you that the correlated antigen levels in different disease phases examined by two studies, which showed consistent results. That is, highest in E positive chronic infection, gradually lower to E negative chronic infection, and at the lowest level in patients with surface antigen seroclearance. If you encounter a first clinic visit of patients with negative surface antigen, you would have 21% chance of diagnosing him as occult hepatitis B infection if you run a test for correlated antigen. It is because when we study 329 patients with surface antigen seroclearance, we find out that 21% had detectable correlated antigen, compared to only 2% had detectable HBV DNA. The diagram further shows you that there were quite a number of patients with measurable correlated antigen in the serum, even after 24 months of surface antigen seroclearance. My next illustration of correlated antigen is its correlation with the established markers of hepatitis B. According to our study, correlated antigen correlate well with the correlation of ratio of 0.7 to serum HBV DNA, intrahepatic total HBV DNA, and also cccDNA. However, the correlation was weaker between correlated antigen and surface antigen levels. Everyone wants to find a reliable surrogate for cccDNA levels in the liver. Our study found out that both correlated antigen and serum HBV DNA had the same correlation ratio of 0.7 compared to only 0.4 for surface antigen to correlate cccDNA. However, if HBV DNA is no longer detectable, as in patients receiving nucleoside therapy, we can still have measurable correlated antigen to correlate the cccDNA in 78% of our patients. In another study, among correlated antigen, surface antigen HBV RNA and HBV DNA, core-related antigen had the highest correlation ratio of 0.85 to cccDNA in both E positive and E negative patients. A third study illustrates the superiority of core-related antigen in terms of the correlation ratios over the serum surface antigen and serum HBV DNA to reflect the total intrahepatic DNA, the cccDNA, and also the p-genomic RNA, as well as the cccDNA transcriptional activities. As I have just mentioned, core-related antigen levels vary according to the different disease phases and correlate well with other serum and intrahepatic biomarkers. What is its clinical significance with respect to the disease milestone, for example, E-cell conversion and progression of the disease, for example, the development of long-term complication of hepatitis B infection? These two studies find out that both spontaneous and treatment-induced E-cell conversion core-related antigen levels at early time points were significantly lower in patients who subsequently underwent E-cell conversion compared to those without. It suggests that core-related antigen is predictive of E-cell conversion in both patients without treatment and patients on nucleoside analog therapy. In this study, not only they find that lower baseline surface antigen was associated with a higher chance of treatment-induced E-cell conversion, illustrated in this left diagram. Lower core-related antigen at the time of E-cell conversion were also associated with a significantly higher chance of sustained E-cell conversion if the treatment was stopped, as illustrated in this particular diagram. So, how about the relationship between core-related antigen and HCC development? This Taiwan study showed in general, increasing core-related antigen levels were associated with a higher risk of HCC. In addition, the role of core-related antigen may even be better or more useful in patients who had intermediate viral load, defined as HBV DNA between 2,000 and 20,000. In this group of patients, core-related antigen greater than 10 Ku per ml was significantly associated with a higher risk of HCC development. We also find that in a group of patients who had spontaneous E-cell conversion, if the core-related antigen levels were greater than 5.2 log, within the first three years of E-cell conversion, the risk of HCC was definitely higher, with the hazard ratio of 1.7. This study examined the significance of core-related antigen after 1 year of nucleoside therapy. It was found out that patients with core-related antigens level greater than 4.9 log for E-positive patients and 4.4 log for E-negative patients would have a significantly higher risk of HCC. Is there a HCC predictive role in patients treated with nucleoside therapy with undetectable HBV DNA? The answer is yes. We find out that core-related antigen was significantly higher in patients with HCC compared to with patients without HCC, although they all had undetectable HBV DNA. And this phenomenon holds true for patients without cirrhosis and patients with cirrhosis. This study documented that core-related antigen lower than 4.8 log at the time of curative HCC development treatment was associated with a significantly higher recurrence-free survival. Now, I come to the treatment effect on core-related antigen. According to our recent study, as illustrated to the by the red arrows here, All three first-line nucleoside analog therapy are able to reduce the COVID antigen, and the reduction was continuous as assessed at the 96 weeks of therapy. In addition, both E positive and E negative patients who would have also continuous correlated antigen reduction on the medium-term therapy. So far, we did not observe any difference in terms of the correlated antigen reduction between entecavir treated versus tenofovir treated populations. Extending to a more long-term therapy, there was a continuous reduction of COVID antigen till the time of assessment up to 7 years of therapy. In this study, COVID antigen level reduced from 2.8 Ku per mil to 0.7 Ku per mil after 7 years of entecavir treatment. My final discussion is on the COVID antigen and is to determine the role of this antigen in HBV reactivation in two special populations: patients with any nucleoside therapy cessation and occult hepatitis patients receiving immunosuppressive therapies. In this recent study, it was found that the lower the COVID antigen at the time of treatment cessation was associated with higher rates of sustained virological response at week 48, higher rates of S loss, and lower rates of ALT flares. And core-related antigen remained to be one of the independent factors for sustained virological response after treatment cessation. 65% of patients with core-related antigen less than 2 log at the time of treatment cessation who had virological response, compared to only 38% in patients with core-related antigen greater than 3 log. Correspondingly, 12% of patients had S loss compared to only 2% S loss in the later group. My final topic is on whether COVID antigen has any role on HBV reactivation in occult hepatitis B infection. The answer again is yes, particularly in those receiving immunosuppressive therapies. In this particular study, we recruited 124 patients who were surface antigen negative and anti-HBc positive and receiving immunosuppressive therapy. 62 received B-cell depleting agent rituximab, and another 62 received allogeneic hematopoietic stem cell transplantation. Overall, the HBV reactivation rate was 40%. Baseline COVID antigen positivity was associated with HBV reactivation with a hazard ratio of nearly 3. For those who were COVID antigen positive, 72% would have HBV reactivation upon immunosuppressive therapy. The diagram on the left shows a significant and great difference in the chance of HBV reactivation in patients with positive COVID antigen at baseline. In fact, as shown in the right diagram, COVID antigen positivity at any time point during follow-up was also associated with a significantly higher chance of HBV reactivation. The role of COVID antigen on HBV reactivation was more pronounced in patients receiving rituximab therapy compared to patients receiving hematopoietic stem cell transplantation. So please remember to check, if possible, for COVID antigen positivity in patients who are going to receive B-cell depleting agents. So in summary, COVID antigen is a useful monitoring tool for different phases of HBV infection. It can detect occult hepatitis B or chronic hepatitis B with surface antigen serum clearance. It correlates with the gold standard of viral replication in the serum, that is the HBV DNA. It highly reflects the intrahepatic HBV DNA and cccDNA contents. We can use COVID antigen to assess the treatment efficacy, and it is also associated with the risk of HCC. It can also predict HBV reactivation in chronic hepatitis B patients with leukocyte cessation and in occult hepatitis B patients receiving immunosuppressive therapy. Finally, I would like to take this chance to acknowledge all my team members who had done so many wonderful studies in Queen Mary Hospital. With that, I would like to thank for your attention.